Hello, I'm Anthony Ishak, a clinical pharmacist and coincidentally the senior author for the paper we're going to discuss today, comparison of home versus clinic blood pressure devices in the clinical setting. I'm going to tell you about 3 things you need to know and 1 you don't about our article. First point, methods. So we compared patients' upper arm automated blood pressure device versus a clinic device for accuracy using the HA-AMA device accuracy test. The clinic device was an Omron HEM 907XL device, which was the same device used in the SPRINT and ACCORD studies and recommended by some guidelines for its ability to do unwitnessed automated office blood pressure readings. We looked at 152 patients who were seen during a clinical pharmacist clinic schedule, which were 30-minute appointments, demonstrating real-world scenarios in terms of trying to do this during an office visit. The 152 patients had an average age of 60 years old, and 58% of which were women. Point number 2, what was the result? Well, we defined failure according to the HA-AMA protocol as a greater than 10 mercury difference between systolic blood pressure readings on a home device versus a clinic device. Overall, 22% of devices failed, but Omron had a lower failure rate at 19%, whereas non-Omron devices had a 28% failure rate. By testing any automated upper arm device that a patient brought in, we showed greater real-world applicability, since oftentimes patients don't buy devices that are on a validated list. Point number 3, strengths and limitations. Well, we did a convenience sample of 152 patients, which might be a small sample, and it would be important to replicate it in larger groups. Because of the COVID pandemic, we're relying on out-of-office readings more and more, and our device adds to the body of literature in terms of making sure devices are accurate before we rely on home readings. The accuracy test by HA-AMA doesn't really account for diastolic hypertension, so it is important to consider it when we're treating patients with widened pulse pressures or patients with isolated diastolic hypertension, that the devices might not have been tested for accuracy for a diastolic component. Since we used any device that a patient could get their hands on, that also has greater applicability. There are hundreds, if not thousands, of devices out there. They've been tested for safety, but not accuracy. So if you stuck with me this long, you're probably wondering, what's one thing that I don't need to know? Well, I'll tell you. Why did we do this study? So the HA-AMA protocol is based on a study that's a decade or more old. That was done by a single provider, similar to here, in 92 patients, so our sample is a little bit bigger. They used a mercury sphygmomanometer. We used an automated blood pressure device, which follows more current guidelines in terms of considering the use of automated device versus manual for the benefit of reducing the chance of human error. We hope that some of these points will entice you to read our article. We look forward to your questions and comments. Thank you for taking the time to watch our video.